Hello, my name is Kristin Crichton. I am a child abuse pediatrician at Nationwide Children's Hospital, and today we're going to be talking about non-accidental trauma. There's a picture of our center, the Center for Family Safety and Healing, which is on Livingston Avenue, right across from the main hospital. Objectives of today's talk are to discuss the unique opportunities that those in emergency medical services have to recognize child abuse, describe common injuries seen in child physical abuse, and discuss mandated reporting and risks associated with missed abuse when we don't report. So just to start with some definitions of child abuse, it is defined in the federal law as any recent act or failure to act on the part of a parent or caretaker which results in death, serious physical or emotional harm, sexual abuse or exploitation, or an act or failure to act which presents an imminent risk of serious harm. So you don't necessarily have to have the harm happen in order for there to be a concern. Certainly if a child's in a risky situation, that could be reportable. Most states recognize four major types of maltreatment in their definitions, and those are neglect, physical abuse, sexual abuse, and emotional abuse. And today we'll primarily be talking about physical abuse, as that is where we see the most concerns arise. So how big is this problem? In 2019, the most recent year of data that we have, there were 4.4 million referrals of child abuse and neglect to children's services that involved 7.9 children nationwide. About half of these, about 2.4 million reports were investigated, and there were about 650,000 substantiated victims. And these numbers don't vary very much from year to year. But I think you can probably appreciate that this is really probably the tip of the iceberg because there's likely lots of injuries and lots of abuse going on that is not reported to children's services. And certainly we see that they only investigated about half of the reports made, so there's probably more happening than these numbers reflect. The rate of victimization is 8.9 per thousand children, and in Ohio it's about 9.9 per thousand children, with a total of 25,470 child victims in 2019. So it's not a small problem. When we look at child maltreatment by type, about 75% of reports to children's services are made for neglect. There's lots of different types of neglect. There's supervisory neglect, so a child is left in a situation where they can hurt themselves, something like a burn that happens because the child's cooking by themselves, or not being properly restrained in a car. There's medical neglect if parents or caregivers fail to fill prescriptions for a child with diabetes or asthma, for example. So neglect comes in lots of different forms and is quite common. Physical abuse is the next most commonly reported type of maltreatment, with 18% of cases being reported for physical abuse, followed by sexual abuse at 9%, and then psychological maltreatment and other. In Ohio, the patterns are a little bit different, with a higher proportion of physical abuse and as well as sexual abuse. You'll notice these numbers add up to more than 100. That's because children are often reported for multiple types of maltreatment at the same time. And when we look at the most extreme cases of maltreatment, those that result in fatalities, we find that about 5 kids die every day in our country as a result of child abuse and neglect. And that is the same rate as children that die as a result of pediatric cancer. So this is, again, it's not a small problem, and it's not an insignificant problem when we have this many children dying. In Ohio, in 2019, we had 78 fatalities, so more than one a week. So we know that child abuse happens, and when we look at what age groups to be most concerned about, it's really the youngest children that are the most vulnerable. Child abuse is the leading cause of head injury in children that are less than 1 year old. Homicide is the leading cause of injury-related deaths in children younger than 4 years. And serious traumatic injuries in children, particularly fatal cases, are rarely accidental unless there's a clear explanation given for the event, like a motor vehicle collision or a fall from a substantial height. Whenever we talk about child abuse, we talk about risk factors, and I'll talk about this today, but then I'm also going to talk about why they don't matter. So at the individual level, looking at individual family, children with disabilities are more likely to be abused because they're more demanding and cause more stress on caregivers. Um, Parental depression, substance abuse is absolutely linked with abuse as well. At the family level, if there's intimate partner, domestic violence occurring in the home, we know any type of violence in the home increases the risk for abuse. Single parent homes, single parents are often more stressed out with providing care for their children. At the community level, if there's dangerous neighborhoods with lack of community support and recreational facilities, that increases risk. And then at the societal level, poverty and low socioeconomic status causes more stress in families that can increase risk. Protective factors, nurturing and attached parents or caregivers. Parents or caregivers that have knowledge of parenting and child and youth development. I think a lot of abuse happens out of frustration for when families or caregivers kind of expect children to not need as much as they do. When you talk to a caregiver and you say, like, tell me about your 4-month old, and they describe a 4-month old as, well, they're really needy. Well, yeah, 4-month olds are needy because they can't do anything for themselves. So that's normal. And so if the caregiver has an appropriate expectation around what caring for an infant is, they're less likely to kind of feel stressed and kind of more able to cope and have more resilience. Social connections, so families that have more social support are protective, concrete supports for parents, and then social and emotional competence of children. But what I want to argue is that risk factors help us identify populations at risk, but they don't necessarily help us with an individual patient. So when we're confronted with an injury in the child right in front of us, what we need to think about is not any of these risk factors. What we need to think about is, does the injury we're seeing match the accidental mechanism that's being described or not? And when we look at kind of patterns of EMS usage and child abuse reports in Franklin County, this was done by one of our child abuse fellows several years ago, we can see that where EMS is being called really overlays exactly with the areas and the neighborhoods where child abuse reports are made in our county. So you all are going to homes and responding to calls exactly where we have concerns for, we've identified higher rates of abuse. This is another heat map with the incidence ratio showing a similar pattern. So now we're going to go through some cases and think about how we can kind of approach these cases. So mom walks in to see her child's father throw the child, who's a 4-month old, across the room. Because mom's worried, she calls 911 and EMS responds. And there's no signs of injury on exam, but the baby is fussy and difficult to console. So what's our level of concern here? Normal exam, but fussy. So let's talk about uh, evaluation of an infant with concern for non-accidental trauma. Young infants that have non-accidental trauma often have very non-specific symptoms because they aren't able to really demonstrate specific symptoms. So in a child that's fussy that may have had a high velocity injury, like being thrown across the room, then we would recommend doing a full workup in this child. That would include a full physical exam, so getting the baby undressed, looking at their skin from head to toe, neuroimaging, which in our hospital is going to involve a head CT. And we do that in all children who are 6 months or younger with concerns for abuse. And we certainly consider it in children that are older if they have any head or neck injury or altered mental status. A skeletal survey, which is a series of x-rays of all of the bones to look for occult bony injury. We recommend that in all children less than 2. Again, we would consider it in older children that have multiple injuries or developmental delay and aren't able to tell us where on their body hurts. And then we also do screening labs for abdominal trauma, so AST, ALT, lipase, and this is done in all children less than 5 years old with injuries concerning for abuse. And if any of these are high, so if AST or ALT is greater than 80 or lipase is over 100, then we would go ahead and get the CT abdomen pelvis to look more closely for injury in these kids. We also do a psychosocial assessment with families so we can kind of understand what their environment looks like for the child. And then when we are concerned, we do make a report to Children's Services, and we'll talk more about mandated reporting coming up. And we have developed kind of a list of indications for when this workup is really indicated. So a cutaneous mark, including a single bruise, burn, or bite mark on a child who's less than 7 months old. So these really young children that aren't able to cause injury to themselves. If we see an injury, we need to think about abuse and doing the workup. Intraoral injury, and we'll talk more about this as well. Subconjunctival hemorrhage. So if we see kind of those red spots in the white part of the eye, if their child's out of that newborn, that real early newborn period, because we do know that birth trauma can cause subconjunctival hemorrhages, that raises concern for non-accidental trauma and would warrant a workup. Really, any type of fracture in an infant without a very clear history of trauma, like a motor vehicle collision, is going to raise concern and need further evaluation. And then unexplained fussiness or vomiting. So like this child that was 4 months old and thrown across the room, no external injuries, but there is fussiness or vomiting, and that may be the only clue that this child gives us that they have an intracranial hemorrhage. Unexplained altered mental status is obviously concerning and would warrant a workup. And then in all contact children, so siblings of children with suspected physical abuse, we would want to go ahead and do the workup and evaluate for occult injury. So moving on to another case, case 2, you're called to the house of a babysitter who believes that the 4-month-old baby in her care has had a seizure. Paramedics respond, baby sleeping, but difficult to arouse, no obvious injuries on exam. And so kind of the question arises, should you transport this child? And I will tell you that this is a real case, and in this case, this child was not transported. Parents ended up coming to the babysitter's home and they called their pediatrician, and the pediatrician recommended the child come to the ED, which was good because when the child came to the ED and had neuroimaging because of the seizure, the child was found to have acute intracranial hemorrhage. So it's a subdural hemorrhage that you can see with the arrow signs there. So this child was a victim of abusive head trauma. So the mechanism is acceleration, deceleration forces, so shaking a baby. We used to call it shaken baby syndrome. We don't say that anymore because that implies that we know the mechanism that happened, and we don't necessarily know. We know that there were acceleration, deceleration forces that may have occurred with or without impact. So the child can be held and shaken very forcefully. This does not happen with routine handling of a baby, or they could be slammed down on a surface and have impact involved in the mechanism as well. There's significant morbidity and mortality with abusive head trauma, and often these children may survive the injury, but will have long-term sequelae in terms of their development and cognitive abilities later in life. Findings that suggest abusive head trauma, subdural hemorrhages like this baby had, retinal hemorrhages, so we do a dilated ophthalmoscopic exam on all of these children and often find retinal hemorrhages, and then diffuse axonal injury, so the shear injury to the axons that again leads to developmental disability later in life. And just like I said with the first case, the symptoms can really be vague or nonspecific. So loss of consciousness obviously is going to prompt concern, but lethargy, irritability, fussiness, vomiting are pretty nonspecific, and this may indicate something else is going on. Lots of babies spit up, and we don't necessarily need to be worried, but we need to understand the context and what else may be going on with the child, and have a low threshold for doing the workup in these young infants, or we will miss abuse. All right, next case. This is a 5-month-old former 28-week preemie who's having breathing issues. You notice some bruising on the face. I hope you can appreciate there's 2 bruises on this child's cheek there. There's actually a third one underneath the jaw. Mom says he slept on his pacifier. Are you concerned at all? Does sleeping on a pacifier typically leave multiple bruises on a child's face? Of course, we're concerned, or I wouldn't be talking about it in this case. So let's talk about bruising and why it's a concerning injury. Lots of kids have lots of bruises, and certainly bruising in older children that are running around and playing and falling accidentally are not concerning. But when we think about bruising in developmental stage, and we think about these pre-ambulatory children, bruising really is concerning because they can't fall and hurt themselves. And when we look at the data, it shows exactly that. In 1999, Naomi Sugar published an article called "Those Who Don't Cruise Rarely Bruise." So it's all in the title. Kids who aren't pulling to stand and starting to walk shouldn't have bruises, and the incidence of bruises is really low in these children, less than 4% in these 2 papers looking at children by developmental stage. In a meta-analysis of similar data, kids less than 6 months old, 1% had bruising. As They get more mobile, they start crawling, they start standing up, they start walking. 10 to 12% can have bruises. And once they're in preschool and they're running around and bumping into each other, all bets are off. Up to 90% can have bruises, and that can be normal. And when we look closer at what other injuries we might find in infants with bruises, there's a study that was done a few years ago looking at children less than 6 months old who had an apparently isolated bruise. So just one bruise, nothing else on exam, no concern for any other symptoms, vomiting, fussiness, none of that, just a bruise. And when the workups were done, skeletal survey showed injury, bony injury in 23.3%, so almost a fourth of them. Neuroimaging found injury in over a quarter of them, 27%, and abdominal injury was seen in about 3%. Overall, 50% had at least one additional serious injury identified by diagnostic testing. And all of these children, and all of those 50% had a high perceived likelihood of abuse. Interestingly, no bleeding disorders were identified amongst this group of infants with one isolated bruise. So it really tells us bruising in young infants should prompt concern for physical abuse, and we need to do that thorough routine approach: physical exam, skeletal survey, neuroimaging, and screening for abdominal injury. Red flag histories for infants with bruising. He laid on something like the case with the pacifier. She must have fallen against the side of the crib. If we were to believe what families tell us about how these injuries happen with cribs, then we would never use cribs. They would be death traps. So cribs really don't cause significant injury unless they're broken or an old, outdated crib. His brother probably did it. I get nervous when we're kind of throwing a 3-year-old brother under the bus. Usually kids aren't hitting each other, especially infants, that hard. She hits herself in the face. Children aren't going to generate enough force to cause bruising on themselves, or a toy fell on him. Unless they're falling from the sky, it's unlikely to cause significant injury. So the key point, bruising in non-ambulatory infants is very rare, and if we see it, we need to think about abuse or some other underlying condition. All right, next case. You're responding to a call about concerns for domestic violence. Mom has a split lip and a black eye, and she's holding her 8-month-old baby, and you notice this. It's kind of a subtle finding on the ear, but it's definitely there. And you ask mom about it, and she says, "Oh, the child's starting to pull to stand, and she probably fell on something." So, what is the significance of, if any, of this injury? So we talked about how kids that can't move around shouldn't have bruises, but as they get older and they have accidental injury, they are going to have more bruises. So then how do we kind of suss out if we're worried about abuse or not? And what we want to think about is the location of the bruise. So in this case, bruising of the pinna is rarely the result of accidental injury. And that's because kids have big heads and they're much more likely to hit the parietal side of their head when they fall than land on their ear. It's generally protected and falls. So bruising of the pinna can happen with blows to the side of the head that can cause petechiae to occur on the external ear. It can also happen with pulling or pinching at the top of the ear that leaves bruises there. Of course, the ear is on your side of your head, so if there is ear bruising, then we want to think about, are we worried about intracranial injury in these infants? So here's different examples of ear bruising. It can be pretty subtle and easily missed. Sometimes kids will only have bruising on the back of the ear, so it's important when we do that thorough skin exam to reflect the ear back and look back there, look in the posterior auricular area of the scalp, look inside the ear. So we see in these other two pictures, there can be bruising just inside the ear and the external part looks okay. So important to do a thorough exam. Other areas where we get worried about bruising: neck. Again, it's hard to fall on your neck. Upper arms and legs are less likely to be injured accidentally. Abdominal wall, there's no bony prominences, so there's nothing hard to impact in the abdominal wall. So if there's bruising there, we're worried. And then buttocks, anus, and genitalia, of course, are protected areas, and bruising there would warrant further investigation. If the bruise looks like a belt, it's probably not from an accident. So patterned bruising conforming to the shape of an object is concerning. And that's in contrast to accidental bruising areas. So bony prominences, forehead, chin, elbows, knees, shins, areas on the front part of the child's body where you can imagine if they fall accidentally and land, exactly where they're going to impact and end up with bruises. And here's a map. Again, accidental injury, forehead, chin, elbows, knees, shins. Non-accidental over those softer areas: ears, cheeks, neck, abdomen. And there's a mnemonic that a child abuse pediatrician who's also emergency room physician, developed 10-4 faces P to help us remember when to be worried. So bruising to the torso, so that's that abdominal bruising, ear or neck in any child less than or equal to 4 years old, or bruising anywhere in a child less than or equal to 4 months old is concerning. Additionally, injury to the frenulum, which we're going to talk about, auricular area, cheek, eyelids, subconjunctival hemorrhage, or pattern bruising. So 10-4 faces P. Those are the injuries and ages that we should be concerned about. So here's some more pictures of kind of protected areas or unusual areas for bruising. So the scalp on the top right there, that is a result of traumatic hair pulling that can cause a subgaleal hemorrhage and leave pretty extensive bruising. This is also a large potential space, and kids can bleed out into this space. So if we do see this, it's important to monitor their hemoglobin, and we have had kids need transfusion. The bottom, there's an example of a significant subconjunctival hemorrhage bilaterally. And then the top left is an example of a pattern injury. You can see the linear bruising. There's two parallel, and this is from a slap mark. So being struck in the face, and you get bruising between where the fingers impacted. Here's another example of a slap mark. So the impact of the hand forces blood in the capillaries to permeate the capillaries, resulting in the outline of the fingers of the hand. When children are hit with inflexible objects, you can get these short linear bruises that follow one plane of the body, and that's in contrast to flexible objects like a rope or an extension cord that'll curve around the body. So you'll see the bruising kind of follow the curvature, and you see this is a pattern injury, and you would not think that this would happen accidentally. Pattern bruising to the buttocks can also happen. You get these lines down the gluteal cleft there because of the convexity of the surface of the buttocks. There's a site of shear injury between impacted and non-impacted tissue, so you get this vertical bruising. As it heals, it can kind of get more diffuse, but that's from spanking. So that raises the question of corporal punishment and physical discipline. And U.S. law states that physical discipline should be limited to buttocks and occur over clothing, and any injury beyond transient redness is considered abuse. That's not super clear, but in terms of what transient is, but kind of our rule is if it leaves a bruise, it's beyond what is considered reasonable for discipline and is reportable to Children's Services. The Ohio law states that the major legal test is whether the parent's actions constituted proper and reasonable parental discipline. I think that's also very gray, but again, if there leaves a bruise, then we report. One of the things that comes up a lot is, can we date bruises by color? And as nice as it would be to be able to say to Children's Services, gosh, we see old and new bruises on this child. They must have been injured multiple times. Really, what the science tells us, and it's there at the bottom of the slide, assessment of the age of a bruise in children is inaccurate and has no scientific basis. And that's for lots of reasons. One, we are all going to look at different colors. We can all look at the same thing and see different colors. I think there's been several viral phenomenon on the internet, like the blue black dress that was gold or white depending on who looked at it. So really the colors in the eye of the beholder. And bruising is going to look different on children or people and it's going to resolve differently because of lots of different factors. So the attachment of the tissue injured, the thickness of the tissue injured, type of force, depth of injury, the underlying color of the injured person's skin, and if they have an underlying medical condition that delays healing. So we really can't date bruises by color. One common abusive bruising mimic is congenital dermal melanocytosis, also known as Mongolian spots. We see this a lot in children with mixed race. We can see it in children that are not mixed, in Caucasian children that are not mixed as well. We'll see these slate gray macules, typically on the lower back and buttocks, but they can really be anywhere. I've seen them on ankles, shoulders, wrists. The true test is that they won't change over time, like a bruise would heal, but these will stay the same over time. All right, moving on to another type of injury that we've kind of mentioned in that 10-4 faces P is Frenula Terror. So that's the F in faces, or frenula. Potential accidental etiologies. So kids are learning to walk and run and trip and fall and faceplant, and they tear that frenula, that thin piece of tissue connecting their lip to their gums. And there's two, the upper lip and lower lip, and then there's a third one under the tongue, the sublingual frenulum. So Simple fall in an ambulatory child, not worried. That definitely happens. And they may seek care because these injuries can bleed a lot. They can happen iatrogenically too with ET tube insertion. But in young infants, we really worry about it because they're not running and falling. And potential abusive etiologies are a blow to the mouth, a slap or punch, forced feeding with a spoon, bottle, or pacifier. You can imagine a caregiver getting kind of frustrated and trying to jam a bottle into a baby's mouth and causing one of these injuries. And unfortunately, we have also seen these injuries with forced oral sex. Again, much like ears, your mouth is in your head. So if there is an infant with a frenula tear, they need to be evaluated for intracranial injury because there may be injury in there as well. So here's an example of frenulum tears. There's an upper labial frenulum tear, or the top two, the sublingual frenulum tear with avulsion of the floor of the mouth actually on the bottom left, and then another upper labial frenulum tear. And this one's starting to heal, so you have that white granulation tissue there. All right, next case. You respond to a call where a 3-year-old has blistering to his buttocks, scrotum, and lower legs, and mom is now refusing to allow you to transport the child. So burns. Let's talk about burns. And we can also talk about mom refusing to allow you to transport the child. Kids get burns in lots of ways. There's thermal burns, so from heat, and there's different types of those. Scald burns from liquid, contact with a hot object or flame burn, chemical burns, electrical burns, friction or pressure burns, and radiation burns. The vast majority of burns in children are scald burns. And there are tons of accidental scald burns, especially with COVID, with kids being at home and so much and kind of heating up their food. This is the time of year where we see a surge in scald burns in the fall when it starts getting cold and kids start making tea and hot chocolate. And then it's up on the counter and they pull it down onto themselves trying to reach the cup and end up with scald burns. Pull down splash burns have a triangular appearance where the greatest burn area is the area of immediate contact with the skin, and then there's a trickle down as the liquid cools down as it runs down the child's body. The burn will often be less severe and less deep. And that's in contrast to immersion burns, where there's more of a uniform burn depth that we see when kids are kind of held forcefully in hot water. There's flexion sparing. So you can see in this slide, the child has sparing in their knees and ankles from where they flexed their leg up and were trying to get out of the hot water. And it spared that skin that was in that flexural surface. And there's a linear contour between burned and unburned skin that's very well demarcated because of being held into the hot water. There may be sparing in areas where the skin was in contact with a cooler surface, like the sink or tub bottom may be cooler than the water itself, and so that the skin in contact with that surface may be less affected. So you get this kind of donut appearance. So when you go to the scene, this is actually an opportunity to really help us in the hospital side understand what has happened. So where was the child when you arrived? Is the child wet? If we're being told that the child was, accidentally climbed into the bathtub and burned themselves, are they wet? Are there wet towels? Are there wet clothes? Is there spilled food, water, tea, ramen noodles? We see a lot. Are there obvious sources of heat near where the child's sleeping or playing? Space heaters, candles, irons. What's the child wearing? Has the caregiver put anything on the wounds? Caregivers put all kinds of things on burns that can change how the burn looks. So it's important for us to understand that history. And then in terms of with that case, in terms of the family refusing transport, that would be an opportunity for EMS to engage law enforcement and reach out to them because they can really help compel the family to come and seek care. So if a family is refusing law enforcement and you're concerned that the child has injuries that need to be medically assessed, I would encourage engaging law enforcement. And in that case, for that scenario, that is what happened, and the family did bring the child in. So mandated reporting. The Ohio Revised Code says that if we, as healthcare providers, have a reasonable suspicion for abuse, then we need to report to Children's Services and/or law enforcement. You don't have to know or possess proof that a child has been maltreated, and as long as you're making that report in good faith, you're not liable for making the report. So when we think about, do I really have to make that report? Oftentimes if you're transporting the child to the hospital, you kind of know that you will make that report. But I think it's important, especially as providers that are have the ability to see the scene and to have responded to the home, there may be information that you have that we don't have here. I really appreciate when you document what you see in run sheets because I look at those on cases that we see, and so that can be very helpful. But if you're concerned and you feel like it needs to be reported, it is mandated that you report to Children's Services or law enforcement. Looking at the thought that someone else will report this, there was a survey in North Carolina that showed that EMS often suspected but didn't report maltreatment. Because they're primarily focused on the child's medical complaint, which is appropriate. We want to make sure the child's stable. Thinking someone else will report, and again, you may have information that people here don't. And I would encourage you, if you're not sure if it rises to the level of reporting, but you do have information, to please make sure you share that with the medical providers and/or social workers at the hospital when you arrive at the hospital. Thinking you need absolute certainty of child maltreatment, you don't. You just have to have reasonable suspicion of child maltreatment, and being unsure of what constitutes child maltreatment. Hopefully, through this presentation, this helps you kind of know more about when to be concerned. And if we don't report, it's a misdemeanor criminal offense to fail to report suspicions of abuse or neglect. But more importantly, and you could jeopardize your license, but more importantly, this child may end up going back to an environment where they're unsafe and sustaining more significant injuries if we can't protect them. So we report to the Children's Services Agency in the county where the child lives. So here's contact information for Franklin County. And then there's also a 1-855 number to report to any county in Ohio. And then local law enforcement where the incident occurred would be involved if necessary. When making a report, you should try to have the name and address of the victim you suspect is being abused or neglected, their age, information about the caregiver, and why you suspect abuse. Any other information that you have can be helpful, but you don't have to have, they ask a lot of questions when you make a report, especially in Franklin County, and you don't have to have all of the answers, and that's okay. That shouldn't prevent you from making the report. So some take-home points: cutaneous injuries are the single most common presentation of physical child abuse. We do want to make sure we're maintaining objectivity and respect for caregivers during evaluation for possible child abuse. So we don't have the role to say, we know that this person abused this child. That's up to Children's Services and law enforcement to help with that part of the investigation. As medical providers, we're identifying the concern for abuse and making the report so it can be investigated appropriately. We know that children who have been abused are at high risk for re-injury, and early detection is extremely important to reduce risk of future harm. History is key. We want to understand the mechanism of injury and if that's plausible to explain their injuries. And mandated reporters are expected to report when they have reasonable suspicion of child maltreatment. These are some sources, and here is my email address if you have any questions: kristin.crichton@nationwidechildrens.org. I really appreciate you taking the time to listen to this, and I appreciate having the opportunity to go over this information with you. Thank you so much.